I was in college during Vietnam and had a very low draft number and was a member of the Air Force ROTC. The Air Force was very good to me. They paid for college, and I was working as an Air Force meteorologist. And I was working night shift, and one night I read in the Air Force Times newspaper that the Air Force was sponsoring officers to go into medicine. And actually, initially, it wasn't something that I had thought about extensively, but the more I thought about it, the more interesting it was. And so I had a background in physics and meteorology, not really traditional backgrounds for medicine, but for my specialty, they're a very good background. Well, as a cancer doctor, we'd like to be able to cure all our patients. Unfortunately, that's not the possibilities because of state of the art in taking care of cancer patients. But I find that almost always with radiation therapy, we can make our patients' quality of life better even when we can't cure them. And fortunately, with modern radiation therapy, with our modern techniques and targeted placement of the radiation energy in the patient, we can minimize side effects. So I guess to put that a different way, I find that we almost always help our patients, and generally we do not cause significant side effects. Well, I think there's several things that go into making a good radiation oncologist. Obviously, we want somebody with empathy for the cancer patient. It seems like many physicians, just as many other lay people, have sort of an aversion for cancer and cancer patients. So a physician who's going to be a radiation oncologist or oncologist of any type for that means has to be able to get over that aversion and accept the fact that we do what we can, we cure the patients that we can cure, and we try to help the rest. So I think that empathy comes first. Secondly, you have to have some bit of mathematics and physics ability. You don't have to be a PhD in physics to do this, but it helps to understand the basic principles of physics, and sometimes that's a little overwhelming for applicants, so we have to find someone who doesn't have those fears, or is at least willing to deal with them and overcome perhaps some of their shortcomings in physics. And then someone who's generally going to be dedicated to practicing quality medicine. So I'd say those three things: empathy for the patients, some abilities in the physics and mathematical aspects, and someone who's willing to put the time and effort into it because it's a very technical field. Well, probably not as much as I'd like to, and not as much as most physicians would like to. My children are grown now, and there probably were times in the past where I could have done better in compromising between my professional and personal responsibilities. I think that's one of the real challenges for physicians, the ability to balance out their personal and professional commitments and be able to make a good compromise between those. Our field has progressed significantly in the 30 or so years that I've been involved in radiation oncology. It's changed dramatically, and it's changed for a couple reasons. One is we've moved forward hand in hand with the improvements and developments in imaging. When I was a young doctor in this field, CT scans were just becoming available. We now have additional imaging abilities, MRIs and PET scans, that allow us to more precisely demonstrate the position of the tumor. And radiation therapy, unlike chemotherapy, is a targeted therapy. We have to direct it to the position of the tumor. It's a local and a regional treatment. Whereas chemotherapy is a systemic therapy. You get the drug absorbed by giving it intravenously or orally, and it circulates around and gets to the tumor. So the development of these new, very accurate imaging modalities, along with significant improvements in the speed and capabilities of computers, and along with that the algorithms that allow us to do things in terms of delivering the dose to the patient that are really non-intuitive. We do a type of radiation called intensity modulated radiation therapy, and basically we call this forward planning, where instead of my having a mental construct of where the tumor is and using a library of radiation fields to get the radiation to the tumor, we outline the target, the area that we want to get a significant dose. We also outline critical structures that are close by, and then we tell the computer, you construct for us a series of radiation fields that gets the dose to the tumor and avoids the critical structures. When we first started doing this, it's such a complex calculation that it would take overnight. It would take 8 or 10 hours for the computer to generate a series of solutions to this problem, and then we always review the computer product to make sure that human beings have looked at it and it's doing what we want to do. Now, fortunately, with the high-speed computers we have, it takes just a few minutes to do what would take 8 or 10 hours previously, and it utilizes a feature in the machines that is different. It used to be that radiation therapy machines, the head of the machine would open in a rectangular field to shape the beam. We now have leaves, multiple leaves that are about a centimeter wide, and not only do they size the field, they shape it, and they can also filter it. That is, sometimes these leaves will be within the radiation field, and in that fashion only allow radiation to get to the target for a portion of the time. So as, these multi-leaf collimators, as they're called, allows us to shape the beam, to filter the beam. We do a type of very elaborate therapy where the machine actually moves as it is treating, and the shape and size of the field is constantly changing as it rotates around the patient. So staying up with those technical developments, being able to understand the anatomy, being able to understand the tolerance of the tissues to radiation has really moved our field forward. Well, I think that students should spend some time in a radiation oncology department. It's a very non-traditional type of therapy. For example, we have nurses in our department, but nurses give us good supportive care, and they're necessary and essential, and I want to keep them. But the people actually doing the therapy are a group of specialists called radiation therapy technologists. So because it doesn't involve medications, it doesn't involve a surgical procedure, I think before anyone would commit themselves to this career, they need to spend several months of rotation in an elective fashion to get to know what the field of radiation oncology is. It's an attractive field, it's a competitive field, it's become one of the top 4 or 5 sought after residencies, and that's good. It's also a field that generally offers good quality of life for the physicians, but I think that an understanding of the non-traditional aspects of radiation oncology would be absolutely essential for someone who thinks they might be interested in this field.